Assalamu alaikum. Hope you are having a good start with your fourth year's second semester part of your curriculum. You're nearly beginning and you are approaching, not beginning, you're approaching to become full doctors. You're finishing your medicine and surgery part. Not the this is the specializations in medicine. So I hope you're proceeding fine, inshallah. Now, today we'll be speaking about the pharmacology of critical care cardiology, the acute conditions, how we are going to deal with them. And the intended outcome will be to classify different drugs used in various types of acute coronary syndrome and to distinguish between the therapeutic policies that will be adopted, whether in ST segment elevation myocardial infarction versus the non-ST segment elevation myocardial infarction, and will correlate the required drugs adopted in such condition to their utility in prevention of another insult and improving the prognosis, the drugs that should be given post insult to protect from another stroke, another acute insult, acute coronary syndrome, and to justify the possible therapeutic regimen in emergency hypertension that should be safe. So when we finish the heart, we'll go to the blood vessels and we'll talk about the emergency hypertension. And also we will explain the different drugs possibly used in hypertensive emergencies. So this means that these are the two branches we're going to speak about. When we speak about the coronary syndromes, we'll speak in a range of diseases as such, the ST segment elevation, the non-ST segment elevation, unstable angina. We will deal with it in the context of non-ST segment elevation myocardial infarction. The point is that when you approach such cases, there are two main issues that we should look at. We know that in unstable angina, there's no biomarkers, no ECG changes, while in the non-ST segment elevation myocardial infarction, we begin to get biomarkers, but we still don't have ECG changes. Once we have an ST segment elevation myocardial infarction, as the name implies, there is ECG changes along with the biomarkers. This is how to identify the situation. When we move to the drugs used in hypertensive crisis, we have two types. We have, as I have said, urgency and emergency. In both, the blood pressure is more than 100 millimeters mercury, 180 millimeters mercury systolic, and 120 millimeter mercury diastolic. And as I said, we divide them into urgency and emergency. The major difference between the two is that with hypertensive emergency, there is presence of acute end organ damage. In urgency, there is no damage. So we are having extra problems in the hypertensive emergencies. Starting with drugs used in acute coronary syndrome. You know the look of that man when he has crushing, stabbing pain. Everybody surrounds him. He cannot tolerate the pain. He is transferred by the ambulance to the hospital. He goes into the ER or transferred immediately to ICU or the CCU according to the hospital. Troponin is done and other cardiac markers. The ECG is done. We know that the underlying lesion sorry is fissuring cracking of an atherosclerotic plaque with the formation of superadded thrombus on top that is nearly occluding or completely occluding the affected coronary vessel. This is it. Let's start with the non-ST segment elevation myocardial infarction. In such case, what are we supposed to do? And we usually deal with unstable angina like the non-ST segment elevation myocardial infarction in the treatment. We usually tackle them together, because the unstable angina is angina that is occurring at rest so much repeatedly, it goes up and down, it stops, and it is relieved by sublingual nitrate or so on. It can be relieved, but it is يعني الإنذار أو the warning bell that this patient is progressing to the non-ST segment elevation myocardial infarction, or directly to the ST segment elevation myocardial infarction. So he have to do it to deal with it as an acute condition, although it is the progression, the normal the progression, but it tells you the progression of stable angina, but it tells you that this stable angina is turning into acute syndrome. So I have to take it seriously. So the treatment is just the same. That's all I want to emphasize. The policy adopted in the treatment of such conditions is to stop thrombus progression, relieve symptoms, and improve survival. There has to be a judgment to all these three entities to be justified in our policy. The policy adopts one or two ways. Either we go on a treatment policy, it's called ischemic guided strategy, we use drugs only, or if the patient has multiple risk factors and he is definitely a critical condition, we can go in early invasive strategy. Now, if we speak about the ischemic or the therapeutic guided strategy, we have two things. We have to give agents that relieve the pain by opening, by dilating the vessel, and these are the anti-ischemic agents, and we have to give the antithrombotic. We have to give a target to the beginning of the formed thrombus that is accumulating on an injured plaque, a vulnerable plaque. So here the situation is treating the thrombus on top of a vulnerable plaque and dilating the vessel. When we want to dilate the vessels or to relieve the pain, at least, it doesn't have to be, we use quickly the nitroglycerine, and we relieve the pain. If it's terrible, we can give up to opiate analgesics. We can give, if there is need, oxygen inhalation. And because the situation is a stressful situation and that patient is receiving aspirin or anything that is irritating the stomach can cause stress ulcers, so we give also proton pump inhibitors. While in the with antithrombotic drugs, we have to give agents that can halt the progression of thrombosis. We want this insult and this problem that is forming at least not to propagate and not to extend. So we are halting its progression by antiplatelets or anticoagulants. In antiplatelets, we have dual antiplatelet therapy, that's aspirin and the thionopyridine group, clopidogrel, or other groups of ADP antagonists like clopidogrel or ticagrelor. Clopidogrel is a cyanopyridine, and ticagrelor is another ADP targeted drug. Both you can give with aspirin as dual antiplatelet therapy. While the anticoagulants that could be given also to help in hospital, of course, he should be transferred to hospital. So in hospital, you can give unfractionated heparin only in hospital because it needs continuous monitoring, and it is short-lived. So we have to follow up the case. You have to have an eye on the case. We can give low molecular weight heparin like enoxaparin, or we can give anti-factor 10 inhibitors, fondaparinux. As you can see, we are choosing in the anticoagulants the things that are given parenterally by injection, so it can act rapidly in such a situation. These anti-ischemic and antithrombotic, what we call ischemic guided strategy, if we adopt the early invasive strategy, we'll do the same. We'll consider them as initiating therapy before the patient goes into the cath lab. So they are the same drugs. They are initiated before before the patient as the patient is entering the cath lab. So they are co-therapy to the procedure, and even we can continue them after the procedure. So with early invasive strategy, when we do a PCI, we have to give these drugs as well. So the add-on event in the treatment is the procedure itself. I hope I am clear enough to say it. So it's the same line of therapy. Let's look at them one by one. Regarding the antiplatelets, الchoice هيبقى ازاي بقى؟ How are we going to choose? Wallahi, the regular thing is that we quickly give, of course, we have aspirin, and we give on top the ADP antagonists. What has been going on for years is, for tens of years, is to give clopidogrel, but bear in mind that clopidogrel is irreversible competitive antagonist to these receptors. That's to say, it works for a prolonged time, and if it's going to work for the prolonged time, then there is chance, if bleeding happens at any instance, it's hard to stop this bleeding. Ticagrelor, the other one, it's been about 5 years or more. I can't recall when it was introduced. It is a reversible allosteric non-competitive antagonist. Now it is beginning to be more commonly used because it is a reversible drug. So, and we can deal with bleeding if it is initiated more easier if it is present. And even if you remember what you took last year, that ticagrelor has also a vasodilating effect, not only an antiplatelet action, but it does have an ATP action which produces vasodilating effect. So now some people prefer to give ticagrelor instead of clopidogrel in dual antiplatelet therapy. The point is that clopidogrel, we have to remember also, because it is irreversible and it is a prodrug, we have to give it as a loading dose, 4 tablets at once, to elevate the steady state in the blood quickly to get an effect in such an acute insult. So this is very important. You have to give a loading dose. While in ticagrelor, you don't need to give this loading dose. This is a second point of difference. Now, regarding the anticoagulants that could be used, in hospital, of course, you don't hesitate to give unfractionated heparin because it has the merit of being very short-acting. Again, if hemorrhage sets in, the effect of heparin will weigh off quickly. هيروح بعد at most 4 ساعات لو احنا during the procedure، مثلا لو احنا خدناه من ضمن البروسيجر. طبعا هنا انا بتكلم على الاسكيميك جايدد strategy، لكن هو بيتحط قبل البروسيجر. So if it's going to be used, being a short acting is good, but the problem, it needs excessive monitoring. We measure it, we judge it also by the activated partial prothrombin time. So in hospital, this is not a problem, but outside the hospital, it is a problem. If you're going to treat outside the hospital of this case, and you're going on a therapeutic strategy, then you give enoxaparin, the low molecular weight heparin, or you can give the non-selective factor 10 inhibitor, which acts indirectly. It is given by injection. It is the fondoparanox. You have to give it injectable. You have to look for anticoagulants as injectable forms in such situation. If we look at the anti-ischemic therapy we have been talking about, what happens that really anti-ischemic therapy, usually, even in developed countries, it starts while the patient is being transferred, or it starts immediately as the patient comes in hospital. But it should be even started either at home or as the patient is being transferred. And nitroglycerin sublingually is the major player in the story, not any nitroglycerin, not any nitrates. You are allowed to repeat it 3 to 5 times, not more. Why? It has to have 5 minutes spacing, so we judge its effect. Why we don't repeat it more than that? Because essentially all the nitrates, they go into the cell of they go into the endothelium, and by certain enzyme that is linked to the presence of SH group, it activates and gets out nitric oxide from these products to act. The SH after some time does not exist, it is taken on. So you need a lot of time to recover it again. So if you give, we usually not exceed 3 times, but some books say 3 to 5 times. If you exceed more, then there will be definitely, definitely, there will be no effect after that. So you use it at the time when you can have an effect. And if it did not bring an effect, well, this could happen. But you're trying to help your patient. In hospital, there are injectable forms. Especially we give it if the patient, we are recording his blood pressure and his blood pressure is high. Opiates is the painkiller in such acute insult, and oxygen when needed, and as we said, proton pumps to be given. Then, what else? What else can we give? We give and we initiate the therapy if we decide an invasive strategy. Well, if the hospital is equipped and the patient reached during suitable time, then we can initiate therapy, not depending on the on the therapeutic strategy, but he can go into the cath lab. So the same previously stated drugs are given in the cath lab. We can give other anticoagulants, other antiplatelets when needed. The glycoprotein 2B3A inhibitors are given when there is, we are afraid of thrombotic complications. The patient has a lot of clots, and you can see in the angio and so on. Or if you did the procedure and there is no flow, so you add glycoprotein 2B3A inhibitors during the cath lab. All of them should not be given if something else was given, especially the direct thrombin inhibitors, like the bivalirudin. Of course, I did not mention it in the things that should be given parenterally because actually it is not present yet in Egypt. But in general, bivalirudin, if it is given, we don't give the glycoprotein 2B3A inhibitors. Also, all of the glycoprotein 2B3As should be cautiously given in renal condition, and we usually use half of the dose. The third thing is, you know that the glycoprotein 2B3A inhibitors are these three. Apiximab has and produces immune reactions in a lot of patients, so we have to take care of this. If we can avoid giving it, the classical one that is commonly given even in our country is tirofiban. This is the more popular one given in the cath lab. Now, once we have finished understanding what should be given regarding the drugs in non-ST segment elevation, or in cases of unstable angina that is proceeding to go into to make the patient enter into a more acute condition. It can progress, as I said, directly to even ST segment elevation myocardial infarction. So in this case, when we have an ST segment elevation myocardial infarction, what are we going to do? Now, the major thing in such a condition is to adopt a reperfusion strategy. And what do we mean by a reperfusion strategy? We have to open the blood vessel, the occluded blood vessel. We have to open it because it's nearly occluded or actually occluded. And the two methods to open it depends on selecting the appropriate strategy. One of them within the specified time frame, because one of them has a strict time frame to give to use. So we have to select the situation. It also depends when we are selecting to weigh the risk to weigh the risk factors so very well. So risk stratification is very important, and you should know your risk, the ways of risk stratification from your rounds in the cardiology unit. There are several ways of risk stratification of the patient. You give scoring, and depending on the outcome of the score, you can justify whether the patient is at high risk or low risk, and this weighs when choosing and selecting the condition. All that we are saying, we have choices when we have a cath lab, when the patient can be transported into a cath lab, and we weigh these against the risks and hazards. But if the patient's in the countryside or very far away from an area where there is no cath lab, then we don't have choices. The only way then, so we'll say that, and we have, before I'm saying that, we have to know that the only way then, because with the opening of the vessel strategy, we either use thrombolytic therapy to lyse the thrombus عشان الفيسل يتفتح نهائي، أو to go into the cath lab to do a PCI. Now, in both instances, we use again the co-therapy or the initiating therapy. فإذا الأدوية اللي قلناها في الأول إن لازم تتعاطى even لو ما فيش أي حاجة غير إن non elevated ST segment elevation myocardial infarction ومش هتعمله PCI، هي دي الأدوية اللي كل مرة بتتعاطى حتى وهو داخل في الكاث lab. So these are the co-therapies and we have to respect this. Now هما اللي عندنا حاجتين majorly، والحاجة التالتة بتبقى غالبا delayed a little bit. If we have an occluded vessel, we adopt one or three strategies, but to us for the first instance, we have two strategies: a thrombolytic strategy and an invasive strategy by intervention. If by angio or by MRI or anything, we know that this invasive will not work and we need a surgical strategy, usually there is some delay in advancing the patient to go to the surgery because surgery needs preparations. So let us speak about them one by one. In thrombolytic therapy, this is the one if you are far away from the hospital and you can't find anything, no cath labs. A lot of hospitals, they have no cath labs even if you're near the hospital next door. I mean, if the service is available, you usually go for an invasive strategy, especially the patients who have ST segment elevation myocardial infarction. Usually not in most of the instances, they are of patients of high risk. Anyhow, let's speak about what we are going to do about thrombolytic strategy. ايه الأدوية اللي هنستخدمها for lysis and breakdown of the thrombus. انكرتوهم كلهم السنة اللي فاتت. احنا all these drugs have been taken last year في الميديسن last term، يعني من أول سنة تالتة من نص السنة بدأتوا تاخدوا الحاجات دي حسب الراوندز بتاعتكم، فأنتوا خدتوا thrombolytic therapies. وعرفتوا ان بعضهم is fibrin specific وبعضهم is fibrin non-specific. طبعا الفايبرين نون سبيسيفيك لو انت في الكونتري سايد او كده ده بيبقى اكتر حاجه available. Its cost is reasonable for anybody, and the problem with it is that it acts non-specifically, not related to the site of the insult, not related to the injury at the coronaries or whatever. It acts systemically more. So that's why it can induce hypotension and bleeding. And at the same time, this streptokinase, the non-specific fibrinolytic اللي انتوا خدتوه عرفتوا منه ان انتوا ما ت... ما ت... ما مش ممكن يبقى يحصل منه allergic reaction لأن هو بيتحضر من streptococcus. It is a product of streptococcus secretion, and it is liable to produce immune reaction in patients who had tonsillitis or pharyngitis within a year. So before giving streptokinase, you have to ask the relatives of the patient whether he did get tonsillitis or not, or pharyngitis or whatever. If there is a recent history of something like that within the last year, so you should hesitate to give it, or you should expect that an immune reaction could happen, and you have to get your treatment with you, how to deal with that patient when an immune reaction develops. Some give it with Phenergan and other antihistaminics while we're giving it. So this is as regards streptokinase. If the condition is better, we're in the big cities and the fibrin-specific fibrinolytic is available, like the tenecteplase, alteplase, retaplase. They are drugs that act in the vicinity and within the thrombus itself, and they're going to lyse it. They're not that much producing the same effect in the circulation. But the problem with these, they are very high. They have high costs. They're thousands and thousands of pounds. They could be thousands of pounds. That's why when the situation is the cost varies. So you give streptokinase and you take care of the dose not to develop hypotension. You have to have anti-bleeding agents surrounding you, and you should care. It should go very slow or with infusion. And you should be expecting that if the patient had tonsillitis, their immune reaction could occur. So this is as regards the therapeutic thrombolytic strategy when a patient has an ST segment elevation, myocardial infarction. We give it with the objective to open the vessel. The vessel has to open. Wallahi, if the situation is good, we go into the invasive strategy. بنفضل نستخدم زي ما قلنا التيكاجريلور احسن من الكلوبيدوجريل وهو داخل البي سي اي. واي؟ اول حاجه زي ما قلنا ان هو مور بورتنت وعنده فازو دايليتنج ايفكت، وان هو اللي انا ما قلتهولكوش قبل كده بقى في المره اللي فاتت ان هو اتس نوت ا برو دراج. يعني ايه برو دراج؟ خدتوها 1000 مره. يعني دي كلوبيدوجريل از برو دراج، عشان كده بنديه فلوتنج دوز. ليه برودراج؟ يعني هيعمل ايه؟ لازم يعدي وهو معدي على الليفر يبقى فيرست ميتابولايزد، لكن ده ما فيهوش الحكايه دي، فلا محتاج رودنج دوز ولا محتاج اي حاجه. وبعدين هو ريفرسبل زي ما قلنا، فلو خايفين من البليدنج يحصل فاتليست it is reversible وكان be controlled if bleeding sets in. فالاونلي ديفرنس هنا يبقى هيخش يعمل القسطره بتاعته، هيعمل الانجيو وبعدين يشوفه يعمل بالون اند ستنت deploy. طيب وانس احنا خلصنا ده، معلش الحاجة الوحيدة بقى اللي فاضلة السيرجري. if we don't resort to surgery never from the start unless the patient ده عنده history واحنا عارفين ان هو عنده multiple vessel وكان جالنا قبل كده او so on والموضوع مترتب من الاول. لكن العادي ان هو بنتفاجئ بعيان ونبص عليه ونعمل مالتي سلايس سي تي او حاجه كده، ونعرف ان هو لو شاكين ان هو مالتيبل فيسل ديزيز بنبص عليه، ولو كان كده او عنده كينكس او عنده حاجات تمنع جود بالونينج اند ستانتنج، يبقى في الحاله دي هيتحول للايه، للاوبن للسيرجيكال استراتيجي. المشكله بقى في الاوبن سيرجيكال استراتيجي ان العيان is an acute condition and you want to keep him living until he makes the surgery, so you have to put him on all the core therapies اللي احنا قلناها دي، بس بتختار الحاجات اللي تبقى اكتر. لو هتخليه، لو الحكايه قريبه within days بتخليه في المستشفى، لو هو لسه التايمينج بيبقى في البيت. فالسelection of drugs قبل السيرجري ديبيندز على هو ده، عشان ده ينفع يتعاطى في بره المستشفى، ده ينفع يتعاطى جوه المستشفى، ده البليدنج تندنسي بتاعه ايه، ده ايه يعني. it is بردك sorting out the story. once you sort out the story اعرف الآتي، ان انا اهم حاجة قبل السيرجري لازم يخش السيرجري ومفيش bleeding tendency، لازم، لان بيتحط على هارت لانج ماشين، كل السيركيوليشن بتبقى outside to proceed on with the surgery. فلازم لو هو الراجل ماشيينه على dual antiplatelet therapy لازم discontinue قبل 24 ساعة. طبعا دي مدة كبيرة بس مضطرين لو هو على جوال انتي بليتلت ثيرابي. لو هو كان في الهوسبيتال وماشي على انفيوجن اوف جلايكوبروتين 2 بي 3 اي لمدة يومين 3 لحد ما يخش السيرجري، ده ممكن ندسكونتينيو 4 ساعات قبل السيرجري. احلى حاجه بقى اللي طلعت الكام يوم دول اللي هو البريدجنج، حاجه اسمها البريدجنج ثيرابي. البريدجنج ثيرابي ده واحد من الدايهيدرو، واحد من البيورينرجيك acting drugs، كانجريلور. ده very quickly acting. it is reversible parenteral ATP analog. it has a rapid onset and a very short duration of action. ولو انا مخليه العيان عندي في المستشفى يوم ولا يومين، لما اديله الدواء ده انا اقدر اوقفه وانا مش خايف within half an hour before surgery. فده unfortunately ده لسه ما جاش مصر بقى، بس I think the future will be to it and it will come. يعني مش زي حاجات تانية، ساعات ما في حاجات ما تجيش مصر على اساس في دوبليكيشن او كده او حاجه تغني عن حاجه، لكن ده ليه وضع خاص ان هو بريدجنج ثيرابي. فلما اقول لك ايه البريدجنج ثيرابي از انتي بليتلتس، هو الكانجلا رو، وانه ما تنسوش ان هو ريفرسبل مختلف عن الكلوبيدوجريل، وان هو بارنترال وبيشتغل فيري كويك. طيب وانس ان عملنا البروسيجرز او اي حاجه، سواء بي سي اي او يعني على حسب السيتويشن، بي سي اي او سيرجري او حتى الثيرابيوتيك استراتيجي، سواء في ال NST segment elevation او ال non-ST segment elevation, we have to follow up the patient with therapy to improve his prognosis and to prevent other insults from happening. اللي عندنا للكلام ده is the dual antiplatelet therapy. لازم نكملهم at least 12 months، وبعد ال 12 months بنعمل reassessment للبيشنت. والله نشوف الهيموراجيك ريسك من الثرومبوتيك ريسك ونكمل ولا ما نكملش. ممكن برضك ندي كارديو سيلكتيف بيتا بلوكرز للعيان اللي ديscharge ده after الانسلت. This cardioselective beta blocker عادة بنبدأها من أول 24 ساعة من الانسلت، إلا لو كان الواحد عنده cardiogenic shock massive usually anterior infarction. We don't we give the cardioselective, but in most of the instances we give a cardioselective beta blocker. it will limit the infarct size. الابوبتوزز اللي حوالين النكروزز ده اللي بالذات في ال ST segment elevation myocardial infarction بيبقى limited، بيقل. بردك بيقلل الفري فاتي acids، واحنا عارفين البيرنينج of the fuel of the free fatty acids is at a higher cost of oxygen and ATP، فهو كده بيخلي الهارت يستخدم الجلوكوز برضك. هو مش زي طبعا الميتابوليك اكتنج دراجز اللي يوز فور انجينا زي ترايميثيدين وكده، لا، بس اتليست من الحاجات اللي بتقلل الفاتي اسيد افيلابيليتي، بس ما بتقللش that much الاكسيديشن زي التاني، وطبعا بيقل الاكسجين ديماند. وبعدين الميزه في البيتا بلوكرز that if at any time some ischemia happen وحصل منها اريزميا، طبعا بيتا بلوكرز are protective. واحنا قلنا هنديهم كده كده كارديو سيلكتيف، الاتينولول، الميتوبرولول او البيزوبرولول، او الجديد اللي هو اللي هو فازو دايليتنج بيتا بلوكر. خلاص. الحاجة التالتة اللي ممكن نديها on prolonged therapy is give high doses of statins. we have to go down، والتارجت بتاعنا لازم يقل عن 100، في ناس بتقول 80، في ناس بتقول 70 in secondary prevention. المهم احنا بنديه من اول يوم، وهدفنا لما بنديه في الانسلت من اول يوم مش عشان اوطي الكوليسترول، ده علشان in the process of synthesis of cholesterol في intermediate compounds وجودها تزود البلاك فولنربيلتي وقفلها. واحنا بنقفل الكوليسترول سينثيز عن طريق الاتش ام جي كو اي ريدكتيز انهبيتورز الستاتينز، اللي تحت الحاجات دي البرودكتس لحد ما الكوليسترول يتكون، دول لو موجودين هيبقى لهم برو انفلاماتوري ايفكت. لما انا بقفلهم in the context of the first few hours of the insult، ده بيبقى beneficial، نقلل الفولنربيلتي، نحسن الاندوثيريال فانكشن، نانهانس بعد كده في الهيلينج نيو فاسكولاريزيشن، حتى بيقولوا بيزود الاندوثيريال بروجينيتور سيلز فور هيلينج، بيقلل الاجريجابيليتي، لهم بنفيتس كتير في اول كام يوم. ما بيبقاش علشان ان احنا نقلل الكوليسترول، ما الكوليسترول نقلله او ما نقللوش مش ده اللي هيوقف لنا الانسلت في لحظتها. بعد كده on long term طبعا احنا بنكمل عليهم، عشان طبيعي احنا عاوزين الكوليسترول ما يزيدش ويبقى موجود to the level of its target in secondary prevention. من الحاجات اللي ممكن نديها بردك بالذات لو في massive infarctions الايس والاربز، او في severe hypertension، يعني البيشنت عنده hypertension and myocardial infarction، وباين ان في somehow there is dysfunction، وممكن يكون العيان هيخش في هارت فيلير او خايفين ويخش في هارت فيلير. احنا بنخاف كمان لما بيحصل هيدنج يبقى يحصل abnormal remodeling بالاكسس، فيبدا يدينا بالذات لو الانفاركشن كبيره. so we give it to prevent the excessive remodeling, we give it to protect the heart and so that it does not post myocardial infarction go into heart failure. The last thing, like the ACE and ARBs, aldosterone antagonists as well, have effect on the ejection fraction. It is indicated when even the ejection fraction becomes low, so it is indicated in patients who will progress to heart failure. Provided that the renal function is fine and there is no hyperkalemia. So these are the choices to keep the patient with good prognosis after all such hazard. The basic requirement is the first three. You give a statin, you give a cardioselective beta blocker, and you give a dual antiplatelet therapy. This is depending on the situation of the patient. If it is massive and you're afraid of excessive remodeling and abnormal remodeling, so you don't want him to go to heart failure, and if he is already went into a heart failure and it looks severe with a low ejection fraction, then you can proceed on. Now, this